Welcome to everyone today, and thank you for participating in today's webinar, AI Medical Assistance Enhancing Patient Care and Workflow Efficiency. I'm Erin Yeck, the Director of Education for the OAFP. We're thrilled to have you with us this afternoon. We are confident this is a presentation you will enjoy. Our speaker today is Dr. Faraz Ghoddusi, a highly experienced family physician who has worked on the national level to help with healthcare policy and public health. Dr. Ghoddusi is a member of the American Academy of Family Physicians, currently serving as the Executive Director and Chief Medical Officer at Healthy Oregon, a nonprofit based in Tigard, Oregon, while teaching as faculty in the departments of family medicine as well as medical informatics and clinical epidemiology at the Oregon Health and Science University. As for content for today's session, at the conclusion of the program, participants should be able to define what AI medical assistants are and their role in clinical workflows when seeing and supporting patients, recognize the administrative challenges that AI and large language models can address, such as documentation overload and inefficiencies, describe key AI capabilities, including medical record summarization, autofilling forms, and generating clinical notes, evaluate the benefits and limitations of AI medical assistance, particularly in terms of accuracy, security, ethical considerations, and potential impact on patient outcomes, assess real-world case studies showcasing AI adoption in healthcare and how it can enhance patient care, and discuss practical considerations for integrating AI medical assistance into clinical practice while maintaining a patient-centered approach. So I hope everyone is all set. Without further ado, we can get started. So Dr. Ghoddusi, I'll go ahead and hand it over to you.
Wonderful. Thank you so much. Hello, everybody. My name is Faraz Ghoddusi. I'm a family medicine physician and faculty here at the Oregon Health and Science University. And I'm really excited to be talking to you all about AI medical assistance, specifically enhancing patient care and workflow efficiencies. Some of the general topics that are going to be covered. Usually I like to sort of set that groundwork and talk about buzzwords and background of AI. We'll gloss over it briefly because, of course, it's important to know the words that we're going to be using throughout. And then dig into those current uses of AI in medicine, talking about care, talking about workflow. And then at the end, we'll wrap up with a lot of the ethical dilemmas of AI in general. As mentioned, I've been working in academia for a long time. I'm excited to finally have a few disclosures. Of course, I'm faculty with the Department of Family Medicine here in the Division of Informatics and Clinical Epidemiology. I'm a consultant and CMIO of Empathia.ai. I'm the Executive Director of Healthy Oregon, which is a digital health nonprofit. And I was recently elected as City Councilor in the City of Tigard. And my City Attorney would like you to know that the opinions expressed are my own and not officially stance of the City of Tigard, in case you had any concerns that it was. So we're going to get started with a lot of the words and verbiage of what AI is, because a lot of times you end up hearing things thrown around like algorithms and machine learning and AI and big data, and a lot of people use them interchangeably, and that's not necessarily inappropriate. We know that words matter. So being able to speak intelligibly, regardless of what you're doing at your institution or within your clinical practice, ends up being important. So big data is exactly what it sounds like. It's that those big data sets that's usually gathered and compiled with a computer that helps sort of gather all of that information all together. So it ends up being that raw data. And that can be compiled many ways. We know about it in use case of the EMR specifically, but you gather it through Amazon purchases, everything that Siri listens to, all of your Google searches, bank statements, etc. The more things that you link to a single account, the more data they have on you as a person, and the more things that they're able to target to you. Right now, obviously, that's primarily used for advertising, but it could be used for a lot more in the near future. When we're talking about algorithms, that ends up being something that we're also very familiar with in the world of medicine. The most common one that we all know about is, the ACLS algorithm. But when computer algorithms first started, really it ended up being things like MyCin was one of the first softwares, and that was a rule-based clinical decision support for antibiotics that really went through the same thing. So an algorithm is you reach a decision point, you decide one versus another, and based on that, you continue to go through decision points until you reach a resolution of the question that you're being asked. Now we start to transition into artificial intelligence in general. So usually, like it says here, they're activities we associate with human thinking. Right now, it's typically done with a computer, but that wasn't always the case. And when we're talking about artificial intelligence versus things like machine learning, This is a bit of a simplification, but for the sake of, talking about it here, you can think of machine learning as kind of being a subset of artificial intelligence. So artificial intelligence is something where we're basically telling this what to do, and it will do things that are sort of human-like. Machine learning is where the machine itself does it without that specific input. And I'll get into some examples of each of these because really they're things that we've been seeing for decades, but we may not be thinking about them as, AI. Most common one we see in our practice is going to be, those preliminary readings with the EKG. So finding A means that you have diagnosis B. So you have an irregular rhythm. We kind of know what's going on, right? So it's very simple, like looking at one particular pattern or one particular thing, telling the computer, hey, this is what that means, so that when it sees it again, it sort of spits that out as the output. And of course, this has been around for quite a long time. Another newer use ends up being in pathology. It's still looking at what artificial intelligence can do. So here we're being very specific and saying, hey, you have this dense lymphocytic stromal infiltrate, and you have these poorly differentiated squamous nests around it, right? There's a higher risk of inflammatory squamous cell with possibility of metastases, right? So you're able to give it a specific input, and by giving it that input, you're able to spit out that output that really helps us evaluate what things are doing. And again, it's going to be used as a tool that really overall helps out significantly in terms of reducing that cognitive burden. It gives us a basis for what to do. Yes, as a teacher, I have to fold down the initial preliminary diagnosis of an EKG when talking to a medical student. But it's something that reduces that cognitive burden because usually it's very sensitive. So if it's normal sinus rhythm, you feel fairly comfortable with that. Obviously, still looking into it. But that sort of started to shift as we talked about machine learning. And to really understand the basis of that, it's important to break things down into structured and unstructured data. So you have a note, generally it's unstructured, but you could turn that into something that's structured, and then you can make that into something that machine learning can use to do something. So this ends up being that key when we're talking about machine learning. So one of the earlier uses was something like a sepsis model, right? So we're using this computer system that's able to learn and adapt without following explicit instructions by using these algorithms and statistical models to analyze and draw inferences for patterns in that data. So with machine learning, it sort of takes that data in, extracts very specific features, classifies it, and then gives us an output. So in looking at something like this example sepsis model, we look, all right, these last three, have sepsis. And the question that we as physicians or clinicians, or really most places that you end up working if you talk to the informatics group or talk to leadership, is how sensitive and specific do we want the model? Because this isn't necessarily something that computer scientists can do. So it's very important that we as clinicians understand what our role is in general when we're starting to talk about machine learning and how they end up making these models. So as a physician, it's important that we create that cutoff where we say yes or no. So that sensitivity or recall versus specificity, or in computer science is called selectivity, and really looking at that sort of receiver operating characteristic. So the sensitivity specificity curve such that we optimize that line. So yes, I can make a very sensitive model where pretty much everyone ends up being at a high risk of getting sepsis, but that's kind of useless because if I say, yeah, they might have sepsis if they have a temperature over 98. Well, that's kind of useless, right? Because there's no real action that ends up being taken afterwards, versus making it so specific that we're basically using the definition of sepsis to put them in the model, where it ends up really being more retrospective than anything else. So we as physicians need to find that in between, where we're able to take those, the risks and benefits of not just what the model does, but what interventions we want to do, and then find that resolution in the end with that. With that, we start to move into deep learning. This is a subset of machine learning that's based on artificial neural networks. Um, But the biggest thing about this is that we don't really have those inputs and we don't have the features specific to extract. So whereas in the previous one, we're able to sort of look at the different weights and be like, okay, well, age isn't as big a risk factor as things like oxygen level, temperature, et cetera, for sepsis. With machine learning, we don't necessarily know what's happening in that middle. So there's tons of data. It kind of does its own thing in this black box, and then we have this output. And that's really the biggest thing about the deep learning specifically, where the middle is that question mark. We don't know what's happening, but we have an input, we have the output, and that's kind of where that ends. When we're talking about natural language processing, this ends up being how we program computers to process and analyze large amounts of natural data. Our goal is to basically have it understand the contents of documents and things like that and be able to contextualize it. So it's able to group words, group phrases. So it takes things like coronary artery disease and bundles it together, knowing that this is one group versus, being coronary artery disease. And that ends up being important in terms of looking at the next steps, because this is what led to GPT, which is something that most people now are quite familiar with. It stands for Generative Pre-trained Transformer. This transformer part of it ends up being really, really important because what that does is it draws attention to certain parts of a conversation. So when we end up having that sort of attention, we're able to look at a phrase, look at something that's been brought forward and discussed, and then draw specific attention to particular parts of that. So instead of just being that sort of next word predictor that we've had in, text messages long ago, we're able to look at specific parts of the word. Obviously, in this history, active suicidal ideation is important. You're not going to talk about hyperlipidemia as much if that happens to be the case, right? And then it's able to focus on things like no trauma, right? Because lower back pain with trauma clearly has a different differential than with no trauma. So it's not able to just take those obvious keywords, but even the subtle words that end up significantly changing the direction of the next step. Um, and it's this attention that has really changed things over these last couple of years. I know that you've all felt it. I've felt it. There's this rapid proliferation of use cases, and these generated results are now useful because of this transformation, which is fantastic and has so many different implications in healthcare. And now that we've sort of talked about what it is and how we got here and why now we're starting to see this, huge growth and all this big change, we're able to really start to target healthcare specifically and look at different avenues where we're able to use this to our benefit. So, in looking at examples in healthcare, there are countless. When I first started giving this lecture about 3 years ago, a lot of these examples, to be honest, was me talking about the future of healthcare. And now this is present, right? And I'm having to update this slide deck every couple of months just because things just keep rapidly changing, which is both great and, it becomes important to sort of know what's happening and what some of the risks are as we move forward. So a lot of what we'll be discussing as a way forward with this specifically ends up being things like risk protection, prediction, and intervention. In the United States, hospital costs for potentially preventable conditions account for about one in every $10 of hospital expenditure. So there end up being, millions of hospital stays and billions of dollars being spent that could be prevented with better risk prevention. So using sort of this AI-driven predictive modeling within the EHR, like that sepsis model that we talked about, can really help with creating predictive modelings and forecasting for things like in-hospital mortality, 30-day unplanned readmission, prolonged length of stay, final discharge diagnosis. It's even used to look at things like ED risk and help with prevention in the ambulatory space. So it's really exciting as we start to move forward to see, different ways that we can find that application in the clinical setting and the hospital setting. When we talk about population health, as the United States moves away from fee-for-service to value-based payments, and the size of population health management starts to increase over time, we're starting to notice more and more that things like macro and MIPS measures end up being important. Finding a way to really focus on that value-based system so that we can do a lot of that preventive care to keep people from even going to the hospital. I'm not going to go into that fee for service versus the value-based system in general because that's more than a topic on its own. But by using this, we're able to do that sort of initial outreach a lot easier. We're able to determine the risk and determine early interventions a lot easier to really keep patients from going into the hospital, which ends up being an important part of it. There is a lot to be said about medical advice and triage. There are a lot of companies that have developed AI doctors that can provide health advice directly to patients with common symptoms. Um, and then there are a lot of EHRs that are using things like generated draft replies. This is an unnamed large electronic health company that basically, whenever a patient sends a my chart message to you, it creates a sort of draft response, and then you as a physician can either start with that draft or you can start with a blank reply. Um, we've done a pilot at our institution. It is interesting. It is not quite there yet, in my opinion. We ended up spending a lot of time reviewing the draft replies and having to respond to that and then adjusting it. So we ended up just reading twice as much as we did before. But it does have a lot of promise. And as we're starting to see the accuracy improve over time, it's going to really start to change things and hopefully reduce our inbox, which is going to be a key factor in reducing that burnout. There's a lot of talk about risk adjustment, paneling, and resourcing. And one of the big things that this could do is, depending on your institution and depending on how you end up using it, hopefully give you as primary care physicians adequate time to address the needs of each patient by either increasing or decreasing panel sizes, complexity, or even the time with each patient based on their sort of complexity. That burnout related turnover costs tens of billions of dollars a year, and the lack of established models for risk adjusting panel sizes led to a lot of potential AI solutions. There are some that use it, like I said, to train that panel size, but another one is looking at level of support that you're needing for primary care practices. And that's not just clinicians, right? It ends up being medical assistants, nurses, APPs, clinical pharmacists, social workers, et cetera, depending on the complexity and intensity of the care being provided. So this is also something that's currently in its infancy, but we're starting to see more and more use cases. And again, our role as physicians is to know what we're going to do with that information when we get it, because we need to be at the table when these decisions are being made. By doing so, we end up sort of playing that role in determining how it's used. So instead of them saying, hey, you can end up seeing all these patients in 10 minutes, we're like, no, let's find a way to improve the care, find a way to see more people, yes, but see them appropriately. One thing that I'm excited for AI to help with is going to be this sort of device integration. About a quarter of the population in America have wearable devices that could track vital signs or other health measures that could theoretically be integrated within the electronic health record. If you have a panel size like I do, if a quarter of your patients have a device that sends vitals to your electronic health record on a daily basis, your inbox will blow up with hundreds and hundreds and hundreds of messages every day, which is a terrifying thought. One of the benefits of AI is that it would be able to help risk stratify, figure out things that should be seen by a physician's eyes, and really help focus and narrow that inbox. Because as more and more people want to integrate what they have, as it goes to the electronic health record, as we know, anything that's being sent to us, we end up to a certain extent being responsible for it. So if you're being sent hundreds to thousands of vitals, if one in that giant stack ends up being something clinically significant, we need to find it and we need to know. And that's going to be one of the really cool pushes as we move forward with AI to help sort of focus our attention so that we no longer have to look at the span of information and really be able to focus on what we need to do as a physician and how we can treat this patient. There are a few other fun uses. One ends up being within the diagnostics. There are a lot of different companies that are using AI in the way that they end up helping with a lot of diagnoses. One thing that we are starting to use here in Oregon is in our more rural areas, we don't have as many ophthalmologists as we would like. So for evaluating diabetic retinopathy, we have there's basically a risk assessment that could be done, and it's able to do the equivalent of a slit exam without us having to actually have people trained to do so. And for those that are higher risk, it actually ends up sending them to our OHSU's ophthalmology program. So although they don't have these in the rural setting, all of a sudden the ones that are being sent to us because OHSU is the only academic medical institution here in Oregon, we're able to send those from rural Oregon here so that they're able to be seen by an ophthalmologist when they necessarily need to. So it ends up doing that risk stratification. It works great with screening, and we're able to get those high touches. Another device that was put together here with some of the physicians at OHSU looks at lesions, skin lesions within the ideally rural setting, but we're also using it here for other reasons. And it determines the risk of a skin lesion being malignant or not. And it's able to hook that patient up with dermatologists that are, quote, in network for this company, so that it creates a direct referral to the dermatologist for excision if you feel that's appropriate. So this ends up benefiting both people for primary care that doesn't want to do that excision or can't do the pathology within clinic. It gets the patient to a dermatologist quickly for that evaluation biopsy. And for the dermatologist, it ends up being a procedure that they get to do. So it's no longer just seeing patients, they get to charge more for it, to be blunt. So everybody ends up winning, and the patient ends up being seen a lot sooner. This was a fun project that I worked on back in the day. So it was very, very early rule-based AI. One of the things that we ended up doing was creating a program that could pre-screen patients that are going to be seen for the day and help triage the appointments to basically solve problems for those that need something simple like refills or paperwork that could have been started by administrative staff, while also finding a way to help stratify patients with things like risk of depression, reported suicidal ideation based on demographics, past medical and surgical history, problem lists, and a few other inputs. With this sort of stratification, clinics were able to focus on things like mental health questionnaires and resources in order to help prevent issues before they really arose. Um, this was really big because I started this program within the military. Of course, there ends up being a huge negative stigma with mental health there, and unfortunately, there's a very high suicide rate. So although things like the PHQ 2 and 9 does a fine job at screening for now, a lot of patients just didn't want to bring it up and didn't want to talk about it. So now if all of a sudden that patient with that pain in the right hip is coming in and given this risk stratification, I'm like, oh, this person has that increased risk. It's something that we could really start to interject into that and create that conversation, make it a lot more natural in the process, which I found really helped a lot of patients. And then COVID came around and everything changed, and this was put on the back burner. But huge potential, something that is being revitalized and really exciting in terms of helping focus our, encounters with our patients. Another big thing that I felt compelled to talk about, because of course I'm in academics and this may not touch everybody, is the use of AI in research. There are a lot of different uses. Most common ends up being idea generation. AI is actually really good at creating novel ideas. It's not something that we think of, but there have been studies that evaluated it, and it actually does a pretty good job. Looking at things like diagnostic support, the sepsis and COVID models, predictive analytics within the electronic health record, reviewing automation, and of course, things like drug discovery pipelines. Um, and when we're looking at big data, specifically looking at how it fits within the research world, it can help evaluate things like that sort of research question, things like that are descriptive, which is like what proportion of the population has familial hyperlipidemia. Um, but really what's interesting is the sort of exploratory side of things where we're looking at things like what possible subtypes of autism are there. And the main reason why I love that exploratory side specifically is it could help sort of change the way that we do the research that we're doing and help really focus a lot of what we want to do in the future. So it helps not just look at what studies we have now, but what studies we may want to do in the future. So a good example would be, let's say I'm a consultant for drug company X, which creates a hypertension medicine, and I want to show that it's more effective than drugs Y and Z. Um, it's better than the current, which are the current standard of care. I get enough data that it shows that it's statistically insignificant if the null value is no change compared to other medications. But for the exploratory analysis, I could be like, well, in this specific phenotype, this subgroup, 40 to 65-year-old, Middle Eastern male, it not only reduces blood pressures, but it reduces all-cause mortality over a 20-year span. Yes, this specifically in terms of what the study was looking for is not necessarily, appropriate or right, but it ends up giving us this future exploration. And that's really where we're starting to see more and more studies. And although admittedly, this does not directly have to do with the AI that's being used, given my, passion for research, I just had to push this too. Um, Going back to the clinical side of things, we obviously see it a ton with clinical decision support. Um, it's being used in a lot of coding review. A lot of AI companies are currently using it. There's a lot of that basic algorithms and preloaded alerts that we're seeing with a lot of the electronic health records with drug-drug interactions, contraindicated labs, dose alerts, etc. So this is something that has been around for a long time because of algorithms. But as we start to move forward, what's exciting is we're going to start seeing more point of care decision support. And this is where AI starts to play a role. So before, it was a bunch of algorithms that were preset put together. Now we're starting to get into that sort of next generation of clinical decision-making platforms, which is going to move beyond just like the alerts and best practice advisories to really provide analytics and evidence-based content for the clinical workflow to drive intended action. That's a lot more individualized. So there are a lot of companies that are currently out there that determine next steps based on patient-oriented outcomes across the nation. And it's able to look at, national studies and national diseases, which ends up being great for things like rare diseases that don't necessarily have quality studies behind them. And then, of course, are things like um, open evidence and other things where you can end up, it has that transparency where it allows users to see sources used to answer questions, including information about why those sources may have been used. It has a great interface if you haven't used it. And it helps provide that sort of point of care decision support so you're able to ask a good clinical question and really able to determine the best next steps. One of the concerns that I see moving forward is as of right now, there's really high quality studies that's being used. As we're starting to see changes in things like PubMed, there may be a change in the quality and transparency as that moves forward. So that's just something to keep in the back of your mind as you continue to use this sort of evidence-based medicine moving forward. And of course, our favorite part, practice management. This is one of the most anticipated applications of AI in medicine, the automation of repetitive clerical tasks that are suffocating most practices. So here we have workflow for prior authorization. So AI could do things like eligibility checks, insurance claims, the prior auth process, appointment reminders, billing, data reporting, analytics, all of the stuff that I didn't go to medical school for. So it could be used to automate these aspects of pre-visit planning, making primary care encounters more efficient and rewarding for not just the patients, but for us, because I don't want to do this. None of us want to do this. I don't want to sit with another insurance company trying to justify a CT scan that I ordered for a patient that needs it. It can help reduce that burden. Um, there are some arguments currently being made that, well, if we're going to be changing things, why don't we just change the whole process and make things that were inefficient and inappropriate obsolete? Although that would be, the best thing to do, I don't think it's actually going to happen anytime soon. So I'd rather have a tool that helps reduce it for now, and then we could fix the bigger problem as we move forward. Um, Another use case ends up being in medical education. There is a company that uses natural language processing to analyze and provide feedback on student summary statements based on cases that are presented. So it gives you a medical case, and then it gives you a summary statement of how you did. And there are a lot of other companies that are getting into this space. So it not just helps with medical students, but a lot of things like social workers, therapists, it's able to sort of give them that use case, create something like a chatbot as well, in order to improve their clinical skills. So it's currently being used a lot in education. Now, a big thing in terms of what we're able to do, regardless of sort of where you're practicing at a large institution, smaller clinic, et cetera, ends up being with this sort of chart review and documentation. When I say chart review, and I'll talk about that briefly first, just because it's sort of a bigger thing, a lot of companies are currently working on a process to help take information that's being put in and sort of compile it into a brief summary statement. So that all of a sudden, if you're a primary care doc, you've seen the patient comes back next year, it gives you a nice summary paragraph of, changes in medication, specialists that they may have seen, procedures, ER visits that they may have gone through. And yes, you can click through each one of those in your electronic health record if it's already all compiled. But by doing it within a small paragraph, you're able to get that sort of summary within a minute or two before seeing the patient. So a lot of potential, and a lot of not just AI companies, but electronic health record companies are also trying to work on this process. Now, when talking about AI scribes, there are a lot of different things that we really want to talk about and look at. For most people, the primary thing ends up being cost. There are a couple of different, levels of costs that you could think of. There are those bigger companies that end up being hundreds and hundreds of dollars per user per month. There are some that do per message rates. Um, and really, they know that one of the biggest drivers of physician burnout in the United States is clinical documentation. So anything that we can do to help sort of reduce that is going to be a benefit. And that's one of the reasons why they're sort of looking at this cost benefit analysis in terms of what will make it worth it. Um, so cost is the biggest thing to look for. Next is going to be security. Most well-known ambient scribe companies have the appropriate securities that you're going to want. They're all going to be HIPAA compliant. A lot of them end up having the SOC 2 or that sort of data to help you keep control of the privacy. The big question to ask is, do you get to keep the data? Or are they then using that data to train other things? Because that ends up being a bigger concern and question in terms of what they're doing with that HPI. Um, and then as we're starting to get bigger, changing global dynamics, things like, are the data centers here in the United States? Are you able to easily access things that you need? And that reliability, readability, and note quality are, of course, very important. I should have really put those three first, but those are things that seem obvious to me as a physician, right? Because if the note quality is garbage and it's not really reliable or readable, then you're not going to do it. But I put the other two, especially with that security, because those aren't really things that most physicians think of when you're moving forward. So again, that reliability and accuracy ends up being good. How it integrates within the workflow ends up being important. And making sure that it can actually improve with you, because most AI companies are able to have that sort of internal improvement. So the more you use it, the more it ends up integrating with what you're doing and being able to play into it. And then there ends up being integration question. So a lot of times at bigger institutions, I know integration can become an issue. Getting that BAA and finding a way to integrate it. Here at OHSU, it's a fairly conservative institution in terms of being at the forefront of things operationally. So research were great, operations, it sort of takes a long time to get to where we want to go. So every time we wanted to integrate anything, we had to go through compliance, we had to go through legal, we took forever to get things through our IT department. And there end up being a lot of roadblocks with that sort of integration. So making sure you look at that and look at how that ends up being done, because again, most institutions want to reduce that risk of security breaches. And the more things that you have integrating with your EHR ends up increasing that risk, right? Because you create a tunnel into your EHR and that could be a vulnerability. So making sure you look at, if you want to go down the route of integration, how risky is it and how practical is it at your institution? Because a lot of places won't. So before you get too invested in seeing like the bells and whistles that they're willing to give you, see what you can actually do wherever you're practicing, because that ends up really playing a role into what is practical and doable. So overall, I am very excited about all of this moving forward. It's one of those things that's going to really help bring back the art of medicine. If I no longer have to, do the I'll call it grunt work of prior authorizations, if I no longer have to spend pajama time documenting, if I no longer have to, spend the whole time doing the adjustment of my diabetics in terms of insulin, and that could already be sort of pre-done, I'm now able to sit down with my patients and talk to them about the underlying issues and the bigger things that are really, the problem. It's not necessarily the insulin that's a problem. It's that this person's eating fast food 3 times a day. Well, let's talk about that. Why are you doing that? All right, let's dig into the lifestyle changes. All right, there are a lot of those underlying patient issues that we're really able to focus on and start to bring forward. And I really do think that this could overall be a benefit to the general health of the population. So as long as we as physicians remain very, at the forefront as we move forward, we're at the table when these decisions are being made, we won't be left behind when all these policies are being created. One of my favorite quotes is, if you're not at the table, you're on the menu. So it's important that we as physicians are at the table when our institutions are making these decisions, because the decisions are going to be made. And if we're not there, we can't advocate for ourselves. And that becomes a problem. So I love all of this. I'm doing tons of work with it, not just at our institution, not just with my nonprofit, but a lot of other places. With all that's this good, what can possibly go wrong? And the answer is lots. There is a lot that could go wrong, unfortunately, with AI. One of the biggest things is that the data is only as good as what it's trained on, right? So when we create a model, when we do something with AI, if we're using garbage in order to compile this data or this information and create the model, then that's really what we end up having in the end. So if current practice is very inequitable, we're actually perpetuating that inequity as we move forward with it. To sort of give you an idea of how this ends up working, I usually like to talk about shoes as a good example. So let's say you're creating a model and you want to tell what is a shoe, and you have everything all around it, and then you have this middle one that's hanging out. And if you are told time and again that shoes have laces, all of a sudden that middle one is not a shoe. So by diversifying the data that's being put in, by improving that sort of input that we end up getting. And this is not just with AI. We're starting to see it more and more with things like biobanks as well. We're starting to get that improved research. We're getting that improved AI output. And overall, we're able to generalize all the information that we have. So now when we talk about best practice, we could really talk about best practice for all, and not, best practice for 50 to 60-year-old Western European white men, right? So we're able to generalize things in order to really improve the health of our diverse population here in the United States, which is really exciting. And it's nice to see and know the ethics. And really the important thing is just sort of keeping the ethics in the back of your mind as you're asking these questions and looking at these models. You're able to start to do that sort of mitigation and help alleviate some of the risks that may be involved. So a good confidence check for a lot of things that we end up doing ends up being that sort of World Health Organization. I skipped over this. When we're talking about ethics, there are a lot of different other ethical issues that we could end up talking about. So we're looking at things like risk assessment. Back in the day, there was the MELD for liver transplants, where they used GFR, which was different for African Americans versus white individuals, and that ended up changing that MELD score. So all of a sudden, liver transplants end up going towards one group versus another. Some other big ethical questions that we need to ask about ends up being data ownership. So if we have this AI information, who owns that data? This is sort of a modern question and version of Henrietta Lacks, if any of you are familiar with that story. So who owns the initial thing, and what really ends up being perpetuated, and who really should? And then things like data bias, explainability, and accountability in the end. And I was talking about the World Health Organization because I really do think that they're a good check for a lot of things that end up being, the ethical aspect of thing. And they actually, a couple of years ago, put together a couple of core principles for AI in medicine. And we could go over those. Of course, we want to protect autonomy. Autonomy is the right to self-govern, make decisions for yourself. promote human well-being, safety, public interest, ensure transparency. That explainability ends up being very difficult. So we can explain a lot with machine learning, but with anything with neural networks or deep learning, we have that black box in the middle, and that becomes difficult. Because if this model says, hey, this person needs this procedure, and does it tell me why? I don't know what to do with that information, right? Because if you are the primary care physician and this says, and there's actually a product that does this that we won't necessarily dig into, but it evaluates risk and determines the need for, a heart valve replacement. If this model says this patient is going to need a heart valve replacement and is sending it to you as a primary care physician, I mean, the reality is I'm going to send them to a cardiologist, because what if that is true and I said no? It's difficult to have that sort of action item with this black box model. So that's the most difficult part of it. Responsibility and accountability. So who ends up being responsible for all the information we get? We talked about that device integration, and the amount of information that we end up getting just grows daily. So who ends up being responsible for that? Well, in the end, we as the physicians are, which is one of the reasons why we're always going to be in the model, because somebody has to be responsible. And of course, we talked a bit about that inclusiveness and equity. Another big thing that people don't really think about ends up being that sort of sustainability. So AI does require significant computing power. And although internally we're working a lot on sustainability and creating governance structures and things like that, it does become a bigger question in terms of environmental factors and sustainability. So overall, AI has inserted itself in medicine. I'm very excited about the future, and I want to thank you all for being with me.
Thank you very much. I appreciate you joining us today. Oh, we do have a question. Let's see here. A lot of entities, Google, IBM, etc., offer AI learning for human platforms. Do you have a recommendation that is particularly physician-friendly, content-focused, use cases, etc.?
I really like open evidence. As of right now, that uses a lot of PubMed information. It gives you very, very good resources. So if you haven't used that, that's my personal favorite. And it's very good for teaching students, because you not just have the answer, but you have why the answer is what it is. So you're able to get those references directly, see if you like the study that they actually cited, and then use that moving forward.
Another question, what are good sources to keep up with the state of the art of AI in medicine or elsewhere?
Every academic institution, I shouldn't say every, many are starting to implement sort of AI studies and AI courses. So it's hard to give one answer. I did a lot of training at Stanford, but we're now starting to integrate more and more here at OHSU. I know I'm an alumni of the University of Wisconsin, so I know that they have a phenomenal informatics group and program, and they're really pushing a lot of their AI products as well. But a lot of the academic institutions are really pushing what they are doing with AI in medicine. In terms of some national communities that are really nice, I really like HIMSS and AMIA, AMIA. And those are two other bigger organizations that focus a lot on medical, not just AI, but informatics in general.
I thank you to everyone who joined us. I hope you enjoyed the session. I know we covered a lot of material. We are grateful to everyone who continues to participate in OAFP programs, and on behalf of the Academy's leadership and staff, we hope that we provided valuable education. Again, we'd like to thank you, Dr. Ghoddusi, for joining us and offering your insight. Thank you for all that you do to advance health in your communities. We keep up the passion and the dedicated work. Dr. Ghoddusi, thank you again for joining us. We appreciate all of your time in preparing this, and have a good rest of the afternoon.
Thank you for having me.
Thank you, everyone.